This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
I am new to UCSF. This is my 4th month here, and tonight I will be speaking to you about psychological stress and cardiovascular disease. I have no conflicts of interest, and this is the outline of my talk tonight. I'm going to talk about what is the definition of psychological stress, potential mechanisms of the relationship between stress and heart or vascular disease, what we call cardiovascular disease. And I'm going to give some examples that are, sort of common for stress, chronic stress in the population. And those examples are going to be about job stress or job strain, negative life events, which we've had some press in the media related to this recently, actually, from our work, and give you some advice about what you can do. And if we have time, I am going to talk to you about a new center called the Nurture Center, which is within the Division of Cardiology and Department of Medicine that I tasked to set up and direct. So psychological stress is rising in the United States. Over 50% of individuals report some form of stress. Indeed, some of this might be related to the climate of financial stress in the United States, and you'll see that financial stress is a major cause of stress for individuals in the US. It actually is the #1 cause of reported stress in stress surveys. So what actually is psychological stress? Couple dictionary definitions. The American Heritage Stedman's Medical Dictionary defines psychological stress as a physical or psychological stimulus that can produce mental or physiological reactions that may lead to illness. So essentially, it is something that happens that is perceived by you, results in a chemical reaction in your body that can result in a disease process. That disease process may be related to the heart. It can be related to your stomach when you get heartburn and gastrointestinal problems, and may be related to irritable bowel syndrome. Tonight we're going to be talking about the relationships at the population level with heart disease. So again, some other definitions, because I think that one of the things about stress is that everyone is stressed, and one wonders, so is this a real topic? And should we be talking about this? But there are actually some clear, distinct definitions. The first definition I want to focus on is the difference between actually acute stress and chronic stress. Acute stress, as you see in the slide, is stress that accompanies episodic negative life events that do not occur on a regular basis. So these things might occur at one point in time and never occur again, or may occur twice in your lifetime. They might be related to chance environmental exposures, such as earthquakes or soccer matches that you're very passionate about. And they might be related to experimental processes where you're taken into a laboratory setting and you're given an acute stressor, like you're given arithmetic problems, for example, and a doctor or a researcher checks your blood pressure, heart rate, and your response to a stressor. Chronic stress is what I am really concerned about, which is defined as stress due to regularly recurring events. They can be environmental events or social conditions that are ongoing. an individual usually perceives a stress that taxes them, that exceeds his or her adaptive capacity for what they're being exposed to. All of stress is subjective, okay? And therein lies part of the research, sort of difficulty related to actually studying stress and disease. But we know that stress is related to clinical depression, HIV progression, sleep disturbance, mental illness, and other physical illnesses. So one of the things is, one of the questions I get a lot is, so everybody is stressed, So what is the point of all of this? We know that everyone is stressed, but we know that stress does cause aging, actually. And this cartoon, not a cartoon, but slide, is supposed to demonstrate that in our lives, we all have gone through, certainly the top and the bottom. We haven't been the president of the United States, but you certainly see over the 8 years that the president ages. And there actually has been a study looking at presidents and stress and aging. There is a relationship. However, our presidents obviously have insurance and can see docs at their beck and call. So if you adjust for the things that might result in a disease process related to stress, at the end of the day, whereas they age, it may not reduce their life expectancy per se. So a little bit of sociology and biology related to the stress response. On this slide, you see something called the stress response and development of the allostatic load. The allostatic load is a term that psychologists use. Medical doctors don't actually use it. Most of my colleagues don't know what allostatic load actually means. So we're going to talk about that for a second. So stress, you might experience a major life event, such as a death in your family, an accident, or something else that you perceive as a stressor. And you perceive that in a particular way, and every single person perceives the stress in a different manner, okay? That is incorporated somehow into processes in the brain that may result in illness. It might result in helplessness, threat, or hypervigilance. One of the things, a solid example of hypervigilance might be stress related to actually racism, for example. It is fairly well documented that folks who expect that they're going to be discriminated against, such as, let's say, gender or racial discrimination, might be very hypervigilant in environments where they might expect to experience that type of stress. They might experience this particular stressor. That stressor can result in physiologic responses, and a physiologic response can be something like a rise in your blood pressure, a rise in your heart rate, rise in certain hormones in your body, for example. But the expression of a rise in blood pressure, a rise in your heart rate, is mediated or moderated by many factors. And those include individual differences, such as our genetics, how we were raised, and our experiences with that stressor or lack of experience with that stressor in the past, and also is mediated by behavioral responses. Some people respond to stress by drinking alcohol. Some people respond to stress by watching TV. Some people respond to stress by overeating. Some people might respond to stress by exercising more. That's usually the opposite. But those factors all incorporate with each other to work on that physiologic response. Now, for most individuals, we're able to handle or adapt to our stress. Okay? So the load of stress is called allostasis. Okay? And for most of us, we're able to, stress is actually normal, and we're able to adapt to it. However, remember on the previous slide, I said it's the perception of something that taxes or has excessive demand. All right? So if we are not able to adequately adapt to the stressor, that is called allostatic load. And the allostatic load is exhibited in our body in many different ways. As it relates to the heart, and actually as it relates to many other organs, indeed, there are three main mechanisms. The first is that you get an overactive flight or fright response, which is called the SNS, sympathetic nervous system stimulation. So you get a revved up, norepinephrine, epinephrine response. It's like if you saw a lion or a snake. Actually, I saw a snake coming through the door of my house, and my heart rate went up, my blood pressure went up, and the first response is you try to, well, some people may run, but the first response actually is that you try to kill the snake or try to get away from it. And so that is, the sympathetic nervous system revving up. The other thing that happens is that in our brain, there are parts of our brain, specifically the hypothalamus, the pituitary, and then the adrenal gland, which is above the kidneys, that sort of express hormones that result in the release of something called CRH, or corticotropin releasing hormone, which actually stimulates the production of cortisol. Cortisol is a normal hormone in our body. It has a, it varies during the day. Levels are high at certain times of the day and lower at other times of the day, and it regulates what happens to other hormones and other substances in our body. The other thing that happens is that you get, your immune system gets revved up. So your inflammatory response gets revved up. And when you get a cut, most of us, our cuts heal because white blood cells go to the area of the cut and work to heal the cut. So you get swelling in the area, it gets red, and that's the inflammatory response in reaction. So our whole body is an inflammatory response, actually. And we have inflammatory responses occurring all the time. But it is, so these three processes happen when you're exposed to a stressor, and they regulate each other. And it is actually the dysregulation of these processes, or the inability of them to regulate each other, that can result in disease. So one more mechanistic slide, and then we're going to get a little bit lighter in terms of the relationship with cardiovascular disease. Here, what you see related to the profiles of allostatic load, or this excessive, taxing of our body resulting in an excessive response, biological response, is that you see basically 3 to 4 profiles of allostatic load depending on who you talk to. So the first, so in general, the top slide shows that when we're exposed to a stressor, your physiologic response, whatever that is, whether it's blood pressure, whether it's heart rate, whether it's an inflammatory response, whether it's a hormone level, goes up, okay? And then after a period of time, the levels, or whatever marker you're checking, sort of goes back down as you, sort of normalize. All right, so that's how most of us in this room will respond. However, with the dysregulation response, there are different types of dysregulation. One is called, and this is actually the psychologists are the ones who've defined these terms. One is called repeated hits phenomenon, where you experience a particular stressor over and over and over again. An example of that might be, a social example of that might be, if you are, for example, living in an environment where you're exposed to adverse conditions, such as, let's say, you are hearing gunshots every day, okay? Then if you hear a gunshot and you live in a neighborhood where you're hearing gunshots, then you might sort of have a particular response, over time to hearing those, shots. If you were in an environment where you are, another example might be, if you're in an environment where you are exposed to a work environment where you feel that your boss doesn't like you, and there's certain sort of interactions in the workplace. This is something you're going into chronically every day. You experience that reaction, you get the stressor, goes down, it goes down, but over time what it does is that it causes actually a disease process to occur in this case, and we're talking about the heart, in the blood vessels, that may cause hardening of the arteries. That's a model for causing cholesterol deposits and so forth in your heart that you'll hear some of the other speakers talk about. So that's one of the factors that goes into that. Then you have another model where it's part of the first model, the repeated hits model, where you don't have the actual adaptation over time, and over time you get a lack of adaptation. And that might be something that, an example of that in literature might be something like diabetes, where the first one is represented by coronary artery disease, or the things that give you heart attacks. Diabetes also can result in heart attacks ultimately. But really what's happened in the lack of an adaptation model is that initially you respond, and then over time you respond less and less and less. You get you also get a chronic illness. The last two models are interesting. I find them very interesting, actually, especially the last one. The first one here is one where you are exposed to a stressor. Your stress response goes up, but it doesn't. It just stays up. It doesn't turn itself off. All right, and an example of that might be, for example, your cortisol levels go up, your inflammatory levels go up, so your immune response is revved up, but it never shuts off, okay? Because they're not, sort of regulating each other in the way that it should. And this can be actually represented by many autoimmune conditions. The last model is a hypo response, where it's also a dysregulation response, where you might get elevated cortisol levels, and the cortisol levels are really supposed to suppress the inflammation levels, but it doesn't, okay? And it could work the other way as well, where your inflammatory biomarkers are up, your cortisol levels are up. Cortisol may or may not go down or up. And this model is represented by things like chronic fatigue syndrome. You may not have an inadequate response to the stressor. So your your certain marker levels may not go up. Now, in the general, I mentioned acute stress. So an example of an acute stressor is, I mentioned earthquakes. In California, you get earthquakes. It's one of the things that terrifies me personally, coming from the East Coast. But I'm told that, you'll get accustomed to it. Nonetheless, you're all aware of this earthquake that, occurred in Northridge, California. It was an earthquake that, ranked about 6.8 on a Richter scale. And what it shows here, related to deaths, were that this earthquake occurred in January 1994. And normally, if you look at the years preceding the earthquake, like, for example, in 1992, I wish I could point at it, you'll note that on the date of the earthquake, there were probably about 20 deaths. Not probably, there were 20 deaths, okay? And the year preceding the earthquake. But then on the date of the earthquake, note, there were approximately about 50 deaths. Most of those deaths, believe it or not, weren't due to trauma. They were due to actual cardiovascular heart attacks, okay, at autopsy. And you'll notice here that in the years after, the week after the earthquake, you'll see this week compared to this week, compared to this week, compared to this week, you'll notice that the numbers here are a little bit lower. So what really happened here was that the heart attacks that were stimulated by this acute event, environmental event, really were going to happen anyway in the next 2 weeks, but the acute environmental event caused it to happen earlier. All right, so these people were going to have a heart attack anyway. So you had a diminution of heart attacks following the event. So that's an example of acute stress. Another example in cardiology, classic of acute stress, is what we call Takotsubo cardiomyopathy, or octopus trap in Japanese. And this is what we call acute emotionally induced cardiomyopathy. And what is a cardiomyopathy? So we know our heart sits in our chest. It's about the size of our fist, the left side of our chest, just about here. And basically, what a cardiomyopathy is that normally our heart squeezes pretty well. All the walls move really well. But in a cardiomyopathy is where your heart doesn't function well. All right, and it may still look like it's squeezing well, but it's not functioning well. In this type of cardiomyopathy, your heart is not squeezing well. A part of the heart. All right, so your heart is like your fist, and there's a part of it's all the walls are supposed to go in just this, but pretty much the same amount. And what you're seeing happening in this picture here is that this is supposed to squeeze in, and it's squeezing in really well, and this part is what we call ballooning out. Normally, this is supposed to be probably like that size. All right? So we call this acute apical ballooning syndrome, or Takotsubo cardiomyopathy, and it occurs usually in folks who have acute emotional stress, such as, let's say they've just heard that their child has died. and you've seen people, faint and they, sort of get admitted to the hospital. They may have a major medical illness and be hospitalized for that major medical illness, and it gets picked up on testing. We're actually going to save questions for the end. And it gets picked up on testing. Now, the key to this diagnosis is that you must make sure that there are no problems with the blood vessels that give blood to the heart, meaning that one of the most common causes for squeezing problems with the heart is actually what some of the other speakers are going to be talking about, which is blockages in the blood vessels or rupture of plaque in the blood vessels that cause heart attacks. Right? So you must make sure that the blood vessels that feed blood to the heart are actually clear. This is a phenomenon I understand that in San Francisco it's actually much more prevalent than in other parts of the country, I'm understanding from my ECHO colleagues. So I find that pretty intriguing. Now, the other another big study that's actually shown a relationship between heart attacks. So AMI is acute myocardial infarction. Myocardial is heart muscle. Infarction is death of the heart muscle, so heart attack basically. Is something called the InterHeart study, which was a large study. It's a worldwide study. It's actually the only one that's been performed that looked at the risk factors for heart disease in multiple countries. It followed 24,000 people and compared people who had heart attacks and people who didn't have heart attacks and looked at what were the main risk factors for causing their heart attacks, okay? And you'll see on the slide, I'm sure all of you have heard, you got to control your blood pressure, you got to control your cholesterol, you got to control, you have to make sure if you're diabetic that your diabetes is well controlled, okay? But nobody ever says to you, you need to make sure that your stress is controlled. Stress levels are controlled. And the point here is in a worldwide study of 52 countries, so lots of different populations of individuals, that when they measured a series of psychosocial parameters, they found that psychosocial problems increase the risk of heart attacks about 2.5-fold. And it actually contributed, there's something called population attributable risk. And what that is that if you took away all the risk factors that contribute to a condition, and you measured looked at one factor, that this particular factor contributed, about 32% of risk. Now, I want to specifically focus on a couple of stressors that, sort of all of us experience in this room. So as a doctor, I experience, job stress. As, in your, life, I'm sure if you worked, you experience job stress. And job stress is one example of a chronic psychological stressor. And we know, as I mentioned to you in previous slides, that there's increasing evidence that psychological stress is related to cardiovascular health. One of the things I want to talk about in this talk a little bit is that women appear to have a higher risk of cardiovascular, CVD means cardiovascular disease effects, due to stress. The reasons for this are unclear, but we do know that acute, again, remember acute is different from chronic, mentally induced stress can result in, or does result actually, in decreases in the heart function, as well as problems on your stress testing. When you do an exercise stress test, for example, and then you do images of the heart to see which part of the heart is getting lights up. The part that lights up is the part that actually is getting good flow. The part that doesn't light up as well as the part that's not getting good flow. We know that, sort of acute stress, mentally induced stress, which might be with an arithmetic test, for example, in a laboratory setting, we see this more commonly, see the changes in heart function more commonly than in somebody who has actual known coronary artery disease who undergoes stress testing. All right? And there have been a bunch of papers published about this in the last year. Anyway, what I want to do, for the sake of time, to be able to talk to you about this, is that in our research, what we've been able to do is look at the relationship between job strain and job stress, and those terms are used interchangeably, and heart disease. And the job strain can be measured using multiple different things. We use something called the Karasek job strain model, but there's an effort reward model, and there's also a job burnout model. So quickly, with regards to job stress in the Karasek model, what you see here is that it combines demand, psychological demand, and control. So psychological demand can include these things on this slide, that you're required to work very fast or you have to work very hard. You have an excessive amount of work, for example. Demand control refers to your decision authority or skill utilization. And basically, you can think of this as, how creative you are able to be at work, how much in control you are of your decisions at work. So it's a combination of these four things. And if you put these four categories together, you have, high demand, low control, high demand, high control, et cetera. And you end up with four categories: passive, low strain, high strain, and active. And I'm curious too, but because for the sake of time, because I was curious to hear from the audience, who do you think falls into these categories? But I have a slide on this. And then the other thing we looked at was job insecurity, which is defined as concern about job loss. In terms of the types of jobs that fall into these categories, so low strain you can think of as low stress, passive is passive, active is actually high demand and high control, actually. So actually physicians fall into that category. So even though we think we're stressed and we're busy and all that, we're losing more control, but we have control over when we take our lunch break, for example. In the healthcare system, somebody who might fall into the category of low control might be a health technician. Who has to, clock in. They can only go for 15 minutes a break or 30 minutes for a break, and they're running in and out, taking blood pressures and heart rates and so forth for patients. So that would be an example of somebody who has high strain. Low strain might be a natural scientist. I'm using a lot of scientific examples here. And passive, an example might be a watchman, for example. So we looked at data in the Women's Health Study, which is a large study of lots of women across the United States. And we looked at whether high job strain and job insecurity was associated with new cardiovascular disease over 10 years of follow-up. We had a sample of 17,415 women, and we looked at heart attacks, stroke, coronary revascularization is referred to as doing the procedures to remove blockages, so angioplasty and stenting, or bypass surgery, and we also looked at cardiovascular death. And what we found was that although there was a relationship between 20% of our sample actually had reported job insecurity, and this was a sample of healthcare professionals actually, and folks who reported job insecurity compared to those who reported that their jobs were secure, were more likely to have cardiovascular risk factors. So they're more likely to be heavier, more likely to have high blood pressure, diabetes, high cholesterol. They're more likely to be physically inactive. What we found in our study was that over 10 years of follow-up relative to women reporting low job strain, high job strain, which is defined as having a highly demanding job and not much control over your job, that there was a 40% increase in total cardiovascular events. There was almost a twofold increase in risk of heart attacks. There was a 40% increase in risk of needing coronary heart procedures. And folks in the active job strain category, so this is where physicians would fall again, this was actually a surprising finding, and we're not still able to understand this, and we're doing more work to try to understand this. There was a 60% increase in total cardiovascular disease. Job insecurity, although it was associated with risk factors for cardiovascular disease, was not associated with heart attacks. We're taking questions at the end. The next part of jobs I want to, briefly talk to you about is the fact that, we've gone through a recession. We've gone through bouts of where the population has had high unemployment rates. We know that during the 2008 period to about 2010 period, the employment rate in the United States approached about 10%. One thing I have to say is that, if you look at underrepresented minorities in the population, usually the numbers double what the general population tracks. So it's usually about 18 to 20% during this time frame. So right now, the unemployment data actually came out about 2 weeks ago, and our unemployment rates nationally are about 5.4%. For racial and ethnic minority groups in the country, it remains at about 10% to 15%. So you ask yourself, and that does not include underemployment. And then when you look at states in the United States where you have differential unemployment rates, I found this intriguing in that when you look at California and you look at places like New York and in the southern United States, that the unemployment rates are relatively higher than the rest of the country. And I say this because there is a relationship between unemployment and heart disease. What this slide shows on the y-axis is the hazard ratio, or sort of the risk of having a heart attack in a population, a large sample of individuals. Their age was about 62 years old. And if you were ever unemployed, so look at the darker bar, you have almost a twofold risk of having a heart attack over about 8 years of follow-up here. And then the number of job losses you have, so as you increase 1 to 2 to 3 to 4, your risk increases. But interestingly enough, and this makes sense, I think it's a common sense kind of thing, after your first year of unemployment, your risk starts to drop. And I think that probably has to do a little bit with coping skills and figuring out what's going to happen to you. We've had also some press recently related to this research study, and this is the last study I'm going to present here. And this is, you may have heard this in the news within the last couple of weeks about traumatic life events and heart attack risk. Again, we looked at folks who had heart attacks and those who didn't have heart attacks and evaluated them for experiencing a traumatic life event or a negative life event in general. And what we found was that negative life events were associated with increased risk of heart attack in women with annual household incomes of less than $50,000. And the traumatic life events, such as death or accident to a spouse or a child in particular, was associated with a 67% increased risk of MI. And there were specific things like financial troubles. This is why I'm presenting this tonight. And again, the deaths are particularly associated with risk. So what are some of the implications and recommendations? We've talked about job and finances and the relationship to heart disease and heart attacks. So what is this, why are you telling me this? So there are this slide demonstrates examples of individual healthcare, employer organization, legislative policy, or research examples of potential interventions. Here I'm going to focus really on the individual. So social support is a big thing. All right, so we know that emotional support is one of the ways to deal with this. This is data from the American Psychological Society. And you can see to your right, folks who were supported compared to those who weren't supported had less stress. They were also more likely to make lifestyle changes in response to their stress, and they were less likely to report being depressed over time. And we know that depression also has an independent association with heart disease. So what are some stress easing strategies? One is getting enough sleep, so roughly about 8 hours sleep per night. As we age, the amount of sleep you need goes down, but it should be about 6 to 7 hours. Physical activity, some form every day, and this could mean just sort of it's cumulative physical activity. So walking a little bit in the morning, walking up a flight of stairs, gets added on to sort of walking up another flight of stairs during the course of the day. But certainly most days of the week, learning relaxation techniques, learning time management skills, which is still an issue I have, confronting stressful situations head on, nurturing yourself, cultivating friendships. So social ties is a big one. And in the healthcare system, we have a lot to do as doctors with actually approaching our patients about, and talking to them about stress, and actually making it part of our armamentarium of things that we ask about. When we ask about high blood pressure, we ask about history of diabetes, but we never ask about, what stresses you have in your life. So some quick stress relief exercises when you have time. And since we don't have a lot of time, I'm just going to say that if you have 1 minute of time, you take a deep breath, pausing for a count of 3. both after inhaling and exhaling. If you have 3 minutes, you sit and you focus and try to think of the places in your body where you have tension, trying to relax the muscles in your face and shoulders, so moving from head to toe, basically. 10 minutes, you sit in a quiet room and breathe deeply. Picture yourself in a special place, whatever special means to you. Special to me means the beach. Focus on sensory pleasures and disengage disruptive talks. I am going to end this lecture. Actually, today is my father's birthday. He passed away about 6 months ago, and I want to dedicate, actually exactly 6 months ago, I want to dedicate this talk in his memory. So if you have any questions at the end, I think we're taking questions at the end. Feel free to come up next question.
Good evening, everyone. It gives me great pleasure to talk to you today about cholesterol. And I think cholesterol is a very important topic, what it is, when to treat it, and how. And there's a lot of confusion out there about cholesterol, when you should treat it, when you shouldn't treat it. And I think part of the reason for this is because of the media frenzy. It seems to be one of the popular topics that the press picks up. And if you're like millions of other Americans and you watch Dr. Oz, please stop watching Dr. Oz. But he has definitely added to the confusion about the new guidelines, what's out there, when we should treat cholesterol and when we shouldn't. So before I start, I just want to do a quick survey. How many people in this room know their numbers? Wonderful. And by the time this talk is over, I'm hoping every single hand will go up when I ask how many people will learn their numbers. So let me start by saying this. Cholesterol is not all bad. Our body actually needs cholesterol for many cellular functions. So it's gotten a really bad reputation because if it's very high or very high for very long, it can be damaging. But it's actually not bad for you. So where does cholesterol come from? There are two main sources of cholesterol. One is your body, and the other is your food. Your body, and in particular your liver, makes the cholesterol that you need and circulates it around your body to your other organs. The food that you take in, and in those people who eat a lot of animal products such as meat, poultry, and dairy products, those people have very high cholesterol. So food is the other source of cholesterol. And these two mechanisms actually talk to each other. So your liver actually produces more cholesterol when you eat a diet that's very high in saturated and trans fats. So let's talk about cholesterol. Who can name a type of cholesterol? I heard excellent. So I heard HDL and I heard LDL. So let's first talk about LDL, low-density lipoprotein, also known as the bad cholesterol. And the way that I remember this is you want to keep your LDL low. So L is for LDL and L is for low. And what LDL does is it's made in the liver, as I said, and it goes and swims around your bloodstream. And it actually gets into the wall of your blood vessel, where it deposits itself and deposits cholesterol, creating what's called an atherosclerotic plaque. And we'll talk a little bit more about why this is a bad thing. I also heard HDL, which is the high-density lipoprotein, or good cholesterol. And remember this by you want to keep your HDL high. And think of the HDL as the garbage man of the body. And what it does is actually the opposite of what the LDL does. It actually pulls the cholesterol out of the fatty plaque, out of the atherosclerotic plaque that's occurring in your blood vessels, and takes it back to the liver, where the liver can then dump it into the bile, and you can get rid of it in your stool. The third thing I heard was triglycerides, and this is the other type of cholesterol that you should know about. Triglycerides form the core of all lipoproteins, and a lipoprotein is basically a complex of lipid and protein together. And you should think of triglycerides really as the building blocks or the Legos that make up the cholesterol. And these are stored in fat cells and used as energy sources for the body. And high levels are found in people who are overweight or have high cholesterol or people who have diabetes. So here's the only math that I'll give you today, and it's an oversimplified equation telling you your total cholesterol score. That's your HDL, your good cholesterol, plus your LDL, your bad cholesterol, plus 20% of your triglycerides, which are those building blocks that we talked about. Now, you may be saying when you get your numbers back from your doctor, there's a whole lot of other numbers on there that you don't understand. And really, those numbers are essentially non-HDL cholesterol, which means everything that's bad, that's not good. So that's just your total cholesterol minus your HDL. And one of the other things you see on there sometimes is the VLDL, or the very low density lipoprotein. And that's just another type of the bad cholesterol. So just think of it as a bad cholesterol. So what does this bad cholesterol do? Well, as I talked about, the cholesterol can form plaque between the layers of the artery walls, and then this plaque can result in inflammation. And the plaque does two things. One is it actually limits the blood flow getting to the organs that are being supplied by that blood vessel. And the second is that if it breaks open, it can cause clots and completely limit blood flow. So let's talk about this in a little more detail. So here are your coronary arteries, which are the blood vessels that feed blood to your heart. Now, if you think about your heart, it's a muscle that pumps all day, every day. And so it needs oxygen constantly. So it needs these blood vessels that are feeding it to be open. What happens when you have high cholesterol is the LDL that's circulating around in your bloodstream goes and deposits itself in the wall of the blood vessels. This results in an inflammatory process where inflammatory cells called macrophages come to the site where the cholesterol is deposited and actually engulf the cholesterol to become even more activated in a form called foam cells. And what these foam cells do is they cause lots and lots of inflammation, which causes the plaque to get bigger and bigger. And so then these are the two mechanisms then by which then the plaque can cause a problem. One is that it can limit the blood flow because it gets bigger and bigger. And these are the types of people that you hear that have angina when they walk up a flight of stairs, because when they exercise their heart and their heart needs more oxygen, that plaque is limiting the amount of blood flow that can get to their heart. The second is that the inflammatory process can actually thin out this cap that sits on top of the plaque and cause the cholesterol to spill over into the bloodstream. And when that happens, the body's reaction is to form a clot. So what this clot does is it completely limits blood flow. So if you think about what happens in your heart, which needs oxygen all the time, if you have an occlusive thrombus or a clot that's completely limiting blood flow, that piece of the heart muscle is deprived of oxygen and starts to get damaged and dies off. And that's what a heart attack is. It should be no surprise that the same process can occur in the blood vessels that feed blood to our brain. And shown here are the carotid artery and the vertebral artery, two of the blood vessels that take blood to our brain. And in the same way that they do damage in the heart, these plaques can cause problems in the brain. And if you have a complete blockage of blood flow to the brain, you have a stroke. And then again, no surprise that the same thing can happen in our legs, and that's called peripheral arterial disease. And people can get cramping and pain in their legs when they walk up a flight of stairs, or sometimes if the plaque ruptures, they can actually get necrosis or ischemia of a leg, causing them to potentially lose that leg. So I see many thin people in this room, and at this point you may be saying, well, all of this is great, but it doesn't really apply to me because I'm thin and I don't need my cholesterol checked. And I would say that that is the exact opposite of the truth. The new ACC-AHA guidelines recommend cholesterol screening for everyone, starting in young adulthood. In fact, the new pediatric guidelines are even recommending cholesterol screening for adolescents because of the rising obesity epidemic in the United States. So even though it's true that overweight or obese people are more likely to have high cholesterol, even thin people can be at risk. And that goes back to the two mechanisms that I talked about in the beginning. One is what you eat. So you could be very, very thin and eat very healthy. But the other is your body's endogenous ability to make cholesterol. And a large part of that is determined by your genetics. So I consider myself a thin person, but I'm of South Asian ancestry. And most South Asians tend to have high cholesterol. And indeed, my cholesterol is off the charts. So you can be very, very thin and still have high cholesterol. So you should discuss with your doctor how frequently you should have your own cholesterol checked. And this will be a factor of your age, your family history, your risk factors, your body mass index, a number of other things. But you need to come up with an individualized plan with your doctor. All right, so you got your cholesterol checked. You listened to me and not to Dr. Oz. And the doctor calls you up and says, your LDL, or bad cholesterol, is high. What should you do? Anyone? I heard diet and I heard exercise. Excellent. So number 1, 2, and 3 should be diet and exercise. And that's the point of this slide. If you're a smoker, I don't even need to tell you, you have to quit smoking. Quit that day, because smoking causes direct damage to the walls of the blood vessel. Smoking causes activation of that thrombus. It causes that plaque to rupture. It's so many bad things that it does to your heart, in addition to all of its other risks, so quit smoking. Diet, as you all said, is very important, and that again goes back to those two mechanisms that I talked about. You can't control your genes, you can't control how much your liver is making, but you can control what you're putting inside your body and your dietary cholesterol. So if you're a person who eats a lot of red meat, or you eat a lot of whole milk, or a lot of other things that are rich in animal fat, then that's something you might want to cut back on, or even consider going fully vegetarian or vegan. Dr. Thorson will be talking about exercise, so I won't harp on it too long, except to say that it raises your HDL, which is that garbage man of the body. So people who exercise can actually see an increase in their HDL and a decrease in their LDL. So two positive mechanisms of exercise, in addition to all the other good things that it does for your stress levels, as Dr. Albert talked about, as well as your risk for diabetes and some of the other things that cause heart disease and stroke. Losing weight is also very important, and I can't emphasize that enough, because fat is actually metabolically active. So fat is not just something that sits in our body, it's actually an organ. It causes resistance to the activity of insulin. It secretes a lot of other factors that can also be metabolically active. So the actual act of even losing weight and losing fat is very important to modulate your cardiovascular risk. And the last thing, which should be number 5 on your priority list after you've done all of the other things I listed, is cholesterol-lowering medications. And the one I'm going to talk about today is statins, because that's the one that everyone talks about. And there are people out there who believe it should be mixed in the drinking water. So I want to survey you guys at the end after we talk about it a little bit. So how do statins work? Well, I told you in the beginning that cholesterol is made in the liver, right? And it's excreted from the liver. So it makes sense. If you want to stop making cholesterol, you stop the enzyme that makes cholesterol. And that's exactly what statins do. So statins stop the assembly of cholesterol and decrease its output from the liver. So they work primarily in the liver, and that's how they work. And in addition to that mechanism, however, they also have an anti-inflammatory mechanism. So remember, I told you the second part of that atherosclerotic plaque was all of that inflammation. And so statins can do a number of things. They can actually reduce the number of foam cells or inflammatory cells inside that plaque. In addition, they can stabilize that cap, or that fibrous coating over the plaque, so you're less likely to rupture it. They cause positive changes in the muscle cells in the wall of the blood vessel, so that muscle can relax a little bit more easier when your body needs blood flow, like when your heart needs blood flow. And then in addition, they cause a favorable change in the circulating inflammatory markers that you have in your bloodstream, things like CRP, C-reactive protein, which we'll talk about in a minute. So this is the million-dollar question. Who needs treatment with statins? And it's been about 1.5 years now since the new American Heart Association, American College of Cardiology guidelines that came out that caught a lot of press, with the primary reason being that many more Americans had the implication of potentially getting treated with statin therapy. And really what this guideline did was to summarize about 25 years of data of clinical trials that had been done with statin therapies. And this included 2 types of clinical trials: primary prevention and secondary prevention. Primary prevention is preventing a heart attack or stroke before it's happened in someone who doesn't have it. Secondary prevention is preventing a second heart attack or stroke before it happens. So these are the 4 groups they identified that would benefit from statin. So there's no question, I think, in anyone's mind in this room that if you've already had a heart attack and stroke, you've already ruptured a plaque, you've already shown that you have atherosclerosis and inflammation, the statin's benefits outweigh its risk, and you should be on a statin. If your cholesterol is off the charts and your low-density lipoprotein, or bad cholesterol, is greater than 190, your risk for developing atherosclerosis is actually so high that you are someone that should be on a statin to lower that low-density lipoprotein to prevent that risk. If you have diabetes, diabetes is a process in which a lot of metabolic abnormalities cause direct damage to the wall of the blood vessel, so they actually make that wall much more susceptible to cholesterol plaque. So diabetics actually have a process of accelerated atherosclerosis where they get these plaques earlier in life and they get more severe stenoses than people who are not diabetic. So for that reason, if you are diabetic, again, the risk-benefit profile favors starting you on statin therapy. And finally, the most controversial group, this is the primary prevention group. This is people who are walking on the street with no known cardiovascular disease, who are middle-aged adults, but who have a predicted risk of 7.5% or higher for having a heart attack or stroke in the next 10 years. Now, you may ask me, well, how do I know who's going to have a heart attack or stroke in the next 10 years? Well, and that's where this new risk calculator comes in, and that's the one that got a lot of debate in the press. So the risk calculator was derived from a number of different ethnicities, from pooling a number of different studies, and after they derived it, they validated it, meaning they checked how good it worked in a number of different cohorts. And we'll talk about the weaknesses and the caveats for it in a minute. But this calculator is available online. There's an app. You can download it if you want. You can all check your own risk over the next 10 years. But here are the factors that go into it. So up here is gender, because as you all know, men have a higher risk of heart disease and stroke compared to women. Next is the good cholesterol, the HDL cholesterol, the good guy. How much good is it doing? Whether or not you have diabetes, because again, that damages the walls of the blood vessel. How old you are. Because believe it or not, as you get older, your blood vessels get stiffer, you're getting much more likely to have higher cholesterol, and you're much more likely to have atherosclerosis. So chronological age is probably the most important driver of the risk in this risk calculator. Next is your total cholesterol. And you notice that LDL is actually not on here, right? The low-density lipoprotein, the one that everybody talks about, the bad cholesterol, is actually not on here, but it's indirectly captured. Because remember I showed you that equation. You have your total cholesterol, and you have your good cholesterol. So everything that's not good is basically considered bad. Whether or not you're in treatment for high blood pressure, what your race is. And again, I'll point out there's only Caucasians and African Americans, and then there's this catch-all other category. And the reason for that is because many of the studies that were done were primarily in these two races. And so there's underrepresentation of, for example, Hispanics, East Asians, Middle Easterns, Pacific Islanders. So those are caveats to think about. What your blood pressure is, and then finally whether or not you smoke, which for everybody in this room should be a no. So here are the caveats that we talked about. The calculator is really only derived and validated in people over the age of 40. So if you're 25 years old and you're wondering whether or not you should be on a statin or what your risk is, one of the things you can do is use your lifetime risk. So rather than using your 10-year risk, because at 25, your 10-year risk is very, very low. Because remember what I said, age is the biggest driver of that calculator. So your 10-year risk will be very low, but your lifetime risk may help you determine whether or not it makes sense for you to start a statin therapy. We talked about race a little bit. In particular, I want to point out that Hispanics and South Asians this calculator underestimates their risk. When we checked it, we noticed that it underestimates their risk, and it actually may overestimate risk in other races, such as East Asians. And the calculator doesn't include things like family history. It doesn't include things like CRP or inflammatory markers like we talked about. So those are additional things that you can use on the side to think about it. And that's when we get to this group. So if your risk is not greater than 7.5% super high, but it's not super low either, less than 5%, you're kind of in that intermediate category where you're 5 to 7.5%. Well, then what do? Should you take a statin or should you not? So these are the things you can use as tiebreakers when deciding whether or not to start statin therapy if you fall into that 5 to 7% category. If you've had family history of premature heart attack or stroke, and what I mean by premature is a first-degree male relative who's had a heart attack or stroke before the age of 55, or a first-degree female relative who's had a heart attack or stroke before the age of 65. If your grandfather had a heart attack at the age of 85, that's not considered a premature family history. Next, we look at C-reactive protein, which I've already alluded to a couple of times. It's an inflammatory marker that swims around in our blood, which may increase our cardiovascular risk. And there's a large trial that came out called the Jupiter trial, where they took healthy people who had normal cholesterols and checked their CRP. And if their CRP was high, they gave them a statin. And if the CRP was low, they didn't give them a statin. And what they found is the people with high CRPs who got treated with statins despite having normal cholesterol actually lived longer, had less heart attacks, and had less strokes. So you can see statins do more than just reduce your cholesterol. They do have a very favorable effect on your inflammatory profile. But that's another thing you can use as a tiebreaker. Calcium score. Everyone talks about a calcium score, and you go to the shopping mall, you can probably get one for $300. But what is it, and what does it represent? Well, I talk about the atherosclerotic plaque and the covering on that atherosclerotic plaque. And as time goes on, calcium deposits on that cover. So basically, if you have a high calcium score, that's sort of a surrogate for you having a lot of atherosclerotic plaque with calcium on top of that. So that's what we mean when we look at our calcium score, and that can be used as a tiebreaker. And then finally, an abnormal ankle brachial index, and that goes back to the slide I showed you about the blood pressure in your legs, how you can get blockages in your legs. So if the blood pressure in your legs is lower than the blood pressure in your arms by a ratio of less than 0.9, that means you have significant blockages in your legs that could be preventing blood flow. So let's take a vote. Who thinks we should mix statins in the drinking water?
Talk about the risk.
I used to think that, and I'm still very much in favor of statins, but I do want to point out that as with any medication, statins are not free of side effects. And the most common side effect that you often hear about, muscle aches and pains, and these can be quite debilitating to the point that people have sometimes trouble even getting up off the toilet or getting out of bed, and it can cause a significant impairment in their daily functioning. The other risk, which is a little bit less rare, about 9 to 12%, but still present, is people who are already predisposed to developing diabetes. The statin can push you over the edge. So if you're somebody who who already has a predisposition for diabetes, and statins change the way that your liver works, and liver is where your insulin is made and your glucose is made, and a lot of those changes happen as well. So the statin can actually accelerate the onset of the diabetes. But despite this, remember what I said, in diabetics, we treat them with statins. So if you're already a diabetic, you get a statin. But if you're right on the edge, and you may develop diabetes, then it's something you need to talk to your doctor about, the risk-benefit profile of whether the statin is going to help you or hurt you. And finally, I want to mention that for those who are unable to take statins because of side effects or because of liver function test abnormalities or for any other reason, but who meet indication based on those guidelines that we talked about, there's a number of other cholesterol-lowering medications out there, in particular niacin, fibrates, and you may have heard of Zetia or ezetimibe. So those are the other ones to think about. So in summary, healthcare providers can identify people who are most likely to have a heart attack or stroke, particularly over the next 10 years, and make sure that they're given effective treatment to reduce their risk. But cholesterol is a critical contributor to this risk. So one of the most empowering things that you all can do is to know your numbers and to manage your numbers. And that includes not just pestering your doctor about a statin, but also exercising, eating right, and keeping track of how you're living your life. So for those people who are unable to take a statin, other cholesterol-lowering drugs may also be beneficial, but do be aware that there's a lot less research to support the use of these drugs. Thank you for your attention.
I'm Ann Thorson. I work as a preventive cardiologist, and so one of the things that I'm asked on almost a daily basis is either somebody has come to me with a family history of somebody in their family having had a heart attack, or the patient, or the person themselves has already had one, and they want to know, what can I do to prevent that heart attack? And I'm going to use the bully pulpit tonight to tell you that I think for a number of reasons, which I'm going to try to point out to you, that if I can give you one piece of advice of how to lower your risk of cardiovascular disease, it's going to be to become more physically active. So just a few statistics. What's the magnitude of this problem? Well, as probably everybody in this room knows, cardiovascular disease is the #1 killer of people in this country and has been for every year since 1900, with the exception of 1918 when the flu epidemic took more people. But about 375,000 people a year die of coronary heart disease. That is what Dr. Coley just showed you, of blocked up arteries causing heart attacks. But if you look at all cardiovascular disease, including stroke, about 610,000 people per year die in the United States. And for those women in the room who still may think that cardiovascular disease is a disease of men, and that your greatest risk is dying of breast cancer, I will tell you that 1 in 3 deaths in the United States in women is due to cardiovascular disease. The most recent statistics for breast cancer are that 1 in 36 women will die directly from their breast cancer. So the risk is much higher for cardiovascular disease, and that's why we need to be putting more efforts and more money into developing prevention strategies. So why do we need physical activity? I mean, after all, weren't we born with a heart that was supposed to beat 60 to 70 times a minute, 365 days a year for, 80 or 90 years? And if you look back through evolution, our heart was really designed to do a lot more physical activity than it's currently being asked to do. Physical activity when we were in the caveman era was obligatory. It wasn't optional. We had to fight or flee from our predators. We had to use physical activity to transport ourselves from one place to another. We had to use it to procure food and shelter. And now what's happened is the Industrial Revolution and the technological revolution have resulted in much fewer demands placed on both our musculoskeletal and our cardiovascular systems. So what we really need to do is take back some of that leisure time that's been created by technology and stress our cardiovascular and muscular systems the way that they were meant to be stressed. 2 or 3 generations ago, there were occupations that demanded a lot more manual labor, but now we sit behind desks and with computer screens in front of us, so we are getting much less physical activity. Modes of transportation have changed. We used to walk upstairs, now we take elevators. We used to be in horses and buggies, riding horses, walking, and now we take cars and airplanes. Even our recreational activities have changed. It used to be that kids would go out and play jump rope and play hide and seek, and now they've got the handheld device called the smartphone, or they're on the internet. And all of this, and even our meals, even preparing our meals, we used to have to stir the pot, right, to make the meal, using our large muscle groups. Now we just pop it out of the container, shove it in the microwave, and that's our meal. So we need physical activity to keep our heart muscle fit, and we need it to keep our skeletal muscles, our other muscles, fit. So is there evidence that physical activity benefits us, benefits our heart, benefits our bodies? And the answer is yes. There is lots and lots of evidence from epidemiologic studies, from randomized controlled studies. And what these studies show us is that regular physical activity results in a lower risk of early death, lower risk of heart disease, lower rate of stroke. And then as Dr. Coley and Dr. Albert were talking about, regular exercise also impacts all of the other known risk factors for cardiovascular disease. So we know that diabetes is a risk factor. Regular physical activity can prevent sometimes or delay the onset of type 2 diabetes. It can also lower blood pressure by 8 to 10 millimeters. It's 15 in some people. It can keep our lipid profiles in better shape so that even absent its effect on the cardiovascular system per se, it impacts the other risk factors that we know cause cardiovascular disease. But you can see it doesn't stop there. It protects us against colon and breast cancer. It helps with weight management. It improves our cardiorespiratory fitness, and that actually plays into, as I'll tell you in a minute, how long we survive. And it helps us as we get older to prevent falls. And as Dr. Albert said, it's also involved in some improvements in cognitive function and in depression. So what about its cognitive benefits? There have been studies looking at people who start from being sedentary or the couch potatoes, and they've looked at questionnaires that assess self-esteem and self-confidence, and they've been able to show that after initiating a regular physical activity program, people have increased self-confidence, increased self-esteem, feel good about their level of fitness. There are also improvements on cognitive tests. My daughter is a college student at Johns Hopkins, and she came home to tell me about a study that they talked about in her psychology class, which was that they actually took two groups of college students, divided them up, and made them do a mental test. And in one group, they allowed them to go out and do some physical activity right before they took the test. The other group was confined to this stuffy room and had to just sit there and wait to take the test. And the people who did the physical activity scored better on the testing. So even short-term physical activity is associated with some improvement in cognitive testing. As Dr. Albert was also talking about, we know that regular physical activity moderates that stress response that we get. All of those neurohormonal systems, the cortisol that gets turned on, the adrenaline systems that get turned on. Regular physical exercise tends to tamp down those responses, which is good for our heart. And in studies that have looked at depression, they have looked at the effect of regular, moderate physical activity and put it up against some of the newer antidepressant medications that are out on the market. And the people who engage in regular physical activity get the same benefit as some of the newer antidepressants. So they get an improvement in their depression scores. We know that coronary artery disease and depression are linked. There have been studies looking at people who have had a heart attack and then using depression scales to see where people score on the depression scale. In patients who've had heart attacks who score high on depression scales and are untreated for their depression, they're twice as likely to go on and have a second heart attack as those who are not depressed. So we know that depression is a factor in coronary disease. But what you guys all really want to know about is, are you going to live longer if you do physical activity, or is it just going to feel longer when you're up on the treadmill? And I want to report to you that you'll actually live longer. This was a study looking at the regular, moderate, or vigorous intensity exercise, and I'm going to tell you and distinguish between those two in a minute. So if we look here, these are the couch potatoes. But if you go along the line here, these are the people that are doing about 60 minutes. So 420 is about 60 minutes, 7 days a week of moderate intensity physical exercise. But I want to have you pay attention, because this comes up over and over again, to this line. If you look at the steepness of that line, one of the most significant improvements is just getting off the couch. Right? Not even doing high-level activity, but just getting off the couch and doing something. And this comes up over and over again. This was a study out of the Cooper Center in Texas, and this is looking at the attributable death risk from various conditions. And you can see here, these are the ones that we know are risk factors for cardiovascular disease. Here's the attributable risk for diabetes, high cholesterol, hypertension, very significant, smoking, significant, obesity over here. But here's low cardiorespiratory fitness. This is the people that are the most physically inactive. And you can see that this confers a significant risk of dying just by being physically inactive. So I showed you all the benefits of exercise. Good things for the heart, good things for cancer, good things for osteoporosis, good things for your brain. So why is it that more than a third of us do no leisure time physical activity? Because that's the statistic, U.S. Prevention Task Force, most recent one. More than a third of us do zero, okay? And women are the greater offenders. Women are more inactive than men are, and older people are more inactive than younger people. About 25% of us up to the age of 45 are physically inactive. But But by the time we get to 75, half of us are sitting on the couch doing nothing. If you look at different ethnic and racial groups, there are variations there too. And this is very complicated because this relates to socioeconomic status, access to safe places to exercise, cultural differences in approaches to physical activity. But the bottom line is that if you look at how many of us are actually engaging what is the current recommended dose of physical activity, it's only about 1 in 5 of us. And I'm going to talk a little bit about what those guidelines are and hopefully show you that they're really not that hard to achieve. So here's my prescription. Be fit. And fit stands for what the components of a good physical activity program are. So you want to have frequency, and we'll talk about how much, intensity, how hard does it have to be, time, how much time do you have to put in, and the type of exercise. So here are the guidelines that are currently still the guidelines that exist, and this is American Heart Association, Health and Human Services. So the guidelines for adults are that we should be trying to get in 150 minutes of moderate intensity exercise a week, or if you want to do less, you can do 75 minutes, but it has to be higher intensity exercise. And you want to sustain the activity for a minimum of 10 minutes. So if you're going to do 30 minutes 5 days a week, which would be reasonable, you can break that up. You can do 10 minutes, 10 minutes, 10 minutes throughout the day. And that's the same as doing the 30 minutes all at once. And that's a little different from the way we used to think about this. And that's a lot easier for some people to fit into their day. In addition to that cardiovascular exercise, we also want to be twice a week throwing in some strength training activity. Remember, we need to use those big muscles instead of the muscles that we're using now, which are all tiny little muscles, right? So we need to recruit our big muscles, our big skeletal muscles, and we want to do that 2 days a week. We get 8 or 10 exercises that target the different muscle groups, and we want to do about 8 to 12 repetitions of that exercise, and that's one set. So what about the intensity of the exercise? How intense does it have to be? So for most of us, it can be very moderate exercise, and that's equivalent to a brisk walk. That's not the saunter. That's not the leisurely stroll, but it's a brisk walk. You should notice an increase in your heart rate. You should still be able to talk to a friend who's walking with you. You shouldn't feel like you can't catch your breath, and that's the talk test. And we want to get to a perceived level of exertion of about 5 to 6 out of 10, and I'm going to show you what that means. So basically, we want to be exercising in the moderate to vigorous range. A combination of moderate and vigorous or vigorous, you can get away with a little bit less time. But you want to be breaking a little bit of a sweat, breathing a little bit hard, and increasing your heart rate. So what are some examples of moderate level physical activity? Brisk walking, we already said, but household cleaning, when you're using large muscle groups, mopping the floor, vacuuming, mowing the lawn, going out and shooting basketball, golf if you are pulling your clubs, not if you are riding in the cart and have the remote control little device that guides your cart around. Biking and swimming at a leisurely pace. So what are examples of more intense exercise? If you're one of those people that wants to minimize your time and get down to that 75 minutes a week, then you have to do a little bit more vigorous exercise, shoveling snow, doing heavy farm labor, baling hay, jogging, intense biking and swimming, singles tennis. Those are examples of more vigorous activity. What if you can't get your head around that intensity scale that I talked about? Well, you can calculate your heart rate to tell you whether you're in that target heart rate zone for moderate intensity. And how do you do that? But you want to estimate your maximal heart rate, and that's a formula. 220 minus your age is your theoretical maximum. That's the fastest your heart should be able to go. It's a bell-shaped curve, so some people will be a little below or a little above. And then you want to take that calculated heart rate and you want to multiply that by 0.6. That's your lower end of your target range, right? So if you're trying to do cardiovascular exercise, you don't want to go below that. And then you can calculate the upper limit by taking that same 220 minus age and multiplying it by 0.8. And if you're keeping your heart rate in beats per minute, somewhere in that range, you're doing moderate intensity exercise. If you're going above 80%, if you're pushing it to 80 to 100%, that's high intensity exercise. I'm going to put a little bit of a plug in. There are all sorts of devices out there, so if you don't like taking your pulse, or you can't count your pulse, or you can't find your pulse, there are all sorts of activity trackers out there, and I'm wearing one called a Fitbit right now. Some of them are quite simple. They just count the number of steps that you take in a day, with 10,000 steps being the American Heart Association's equivalent of moderate activity exercise in a day. But some of them are more sophisticated. This one will tell me how many stairs I've climbed, how many, how many steps I've taken, how many stairs I've climbed, how many calories I've expended, how well I've slept last night. And they're at varying levels of price, as you can imagine. But I think the good thing about these is that they can be very helpful to motivate people to get into an exercise routine. I mean, this one will say, congratulations, you've climbed the equivalent of Mount Everest, or something like that. And so I think they can be motivational to help people get started in exercise and track their improvements over time, because you can put all this into a computer and it will show you what you've done in the last month. Again, the other component after you do the cardiovascular exercise is the muscular strengthening. And I think on the handout I gave you some resources in terms of websites. There are several websites. The American Heart Association has a lot of information about exercises and actually has a video showing you various strength training exercises. But you want to do this about twice a week with a day of rest in between. What about older adults? If you're over 65, do you get a pass on all of this? And the answer is absolutely not. The recommendation for aerobic exercise is exactly the same, 150 minutes of moderate intensity exercise. And that's, that would break down into 30 minutes, half an hour, 5 days a week. Not that much, right? And the strength training is the same, except more repetitions if you're older to keep the muscles toned, but with lower weights. Another thing I wanted to add is I don't think you need to spend money to go out and get a set of weights to do all these training exercises. If you want, the simplest thing you can do is get those liter bottles of water. Those weigh 2.2 pounds. Use those as your weights. They're cheap. Then when you graduate, you can go to the 2-liter bottles, and that's 4.4 pounds. And that's the kinds of weights we're talking about. So you don't have to go out and get fancy weights. Okay, so if I'm telling you that exercise is the best medicine around, if physical activity is the best medicine around to prevent heart disease, you're going to ask me, well, what are the side effects of that medicine? Because all medicine has side effects, right? And exercise has some side effects associated with it. There is a slight chance that you're going to get injured, right? And that increases with the amount of exercise you do, the time that you do, the duration of exercise, and the intensity. But also, I would recommend that you try to vary the activities that you do, because if you do the same thing every single day, your risk of injury is higher. If you vary the activities, you're going to be using slightly different muscle groups, and you're much less likely to get injured. And also, it's not as boring if you're not doing the same thing every day. There are rare cardiovascular events that can occur with exercise. I mean, sudden death is reported with exercise, but I want to tell you that's a rare event. Only about, in the sudden death literature, and Dr. Byron Lee will be talking about this in weeks to come, only about 5% of all sudden cardiac deaths are associated with exercising. That means 95% of sudden death happens when you're not exercising. So that's far, the benefits far outweigh the risks. And the person who's the most at risk, and I just want to make a comment about this, the person that's the most at risk for having an event when they're exercising is the weekend warrior. The person who does nothing all year and then decides to go out and run the Beta Breakers, right? That is the person that is most at risk for having an event. The person that's least likely to have an event is not necessarily the sedentary person who never does anything. It's the person who's doing moderate, regular physical activity. That is the person that's least likely to have an event. I want to finish up just with this study. This was recently published in the Journal of the American Medical Association. And the authors, this was a pooled cohort study where they took the data from 6 other studies, and they looked at what they were trying to look at was whether that exercise prescription of 150 minutes of moderate intensity activity a week was too much, too little in terms of mortality. So what they did was they looked at these 6 studies, and just to be, this slide isn't showing up very well. These were the couch potatoes up here. This was the risk for the couch potatoes. And then here was the risk for people who were doing the recommended dose of exercise, that 150 minutes. So, I lost my mouse. Here were people that were doing about twice that, 2 to 3 times that. So these were people who were doing about an hour a day, 5 days a week. And here were people that were doing a little bit more than that. But you see that it kind of flattens out down here, right? So these were people over here who were doing 10 times as much. And they didn't get any additional mortality benefit out of this at all. So the conclusion of the study was that compared with people that did no physical activity, you actually saw a 20% mortality reduction just by getting off the couch. You didn't even have to do the recommended dose of exercise. You could do 60 minutes a week and still get benefit. At the recommended, the current guideline level, you had about a 31% reduction in mortality. If you did twice as much, you got a little bit more. You got up to 37%. After that, it pretty much leveled off. So the conclusion of this was that the guidelines that are on the books are pretty good. These are pretty good guidelines for us to stick with. The other thing that was important about this study is some studies have shown that if you do very high intensity and high level exercise, your risk of dying actually goes up. And this is still somewhat controversial. This study did not show that. And it showed that up to at 10 times the recommended dose, you didn't have an increase in your mortality. And this is important because now we're seeing people doing, 500,000 people participated in marathons last year. Another 500,000 did triathlons, high intensity exercise. So we want to know that it's okay for people who want to do that kind of thing to be doing that kind of exercise and not have an increased risk. So I'm going to finish up by telling you that I think increasing physical activity for all of us is probably the most important prescription of all. It's certainly the cheapest medicine we have for cardiovascular disease prevention. The prescription, be fit, frequency, intensity, time, type, as we discussed, and in the interest of time, I'm just going to say that the trick to this is how to keep it going, right? We all get started on exercise or physical activity programs, and the trick is how to keep it going. And I've struggled with this as much as anybody has. I think the main trick is to not view this as a quick fix. You don't do this just so you can get into that skinny dress for the wedding you have to go to. You're doing this to improve your quality of life, probably improve your quantity of life, and to be able to be active well into your later years. You want to set realistic goals. You're not going to go out and do an hour of exercise if you've been on the couch. That's just silly. You can get into trouble that way. So set a realistic goal. If you haven't been an exercise person, start with 5 or 10 minutes at a stretch and add 5 minutes a week onto that. Vary your activities because it makes it more interesting, and if it's more interesting, you're more likely to stick with it. Buddy up with somebody else who wants to try to do the same thing, because when they call you and say, "Where are you? I'm here to do our walk," that can be a motivational factor. Some people actually are doing walking meetings at their workplace. Instead of everybody sitting around the conference table, they actually are grabbing their colleagues and going and doing their meeting while they're walking. If it helps you, use gizmos, gadgets. Get a new pair of fun shoes, if that motivates you, TV, fast music, anything that'll get you engaged and keep you going. I'm a big proponent of all of that. don't worry about setbacks. We all have them. We all get injured. We all get the flu. We all have deaths in our family that set us back for a while. I think the take-home message is, do what you can. Some is better than none. And reward your successes. And if you need to, hire a trainer. Sometimes that's money well spent to get you on track. Get somebody who can help get you motivated, show you how to use the equipment. Even one session can sometimes be money very well spent to get you on track. So with that, I think we'll all wrap up, and I think that we'll bring all three of us up here and take questions from the audience.
So the question was the negative impact of statins on the liver. So as I explained, statins do act in the liver, and the most common thing that they can cause, or negative impact they can cause in the liver, is an elevation of your liver function tests. Now, these are tests that basically tell us how your liver cells are functioning. They're blood tests that are done, and they're called your ALT and your AST, and your doctor often checks them before you start a statin. And the guidelines say at some point after you've started a statin therapy to also check them again. And we really start to worry when these numbers go up above 3 times the upper limit of normal. So normal is around the 30 to 50 range for ALT and AST. And if you're starting to get into 150 or so, that's when we start to worry, and we may actually stop statin therapy because of that. And what that suggests to us is something about the way that the enzyme that's being inhibited in the liver is affecting the liver cells, is actually causing the cells to not function as well, or sometimes potentially even burst open and spill the enzyme ALT and AST into the bloodstream. So it's kind of a marker that we use. And often when people have elevations in their liver function test, they're not symptomatic. For them to have symptoms, it really takes much larger elevations in their liver function test. So it's more of a screening thing that we do after we start you on a statin therapy to see. And sometimes people who start statin therapy will bump their liver function tests a little bit, but not more than 3 times, and we keep them on a statin, and they either normalize or they stay up a little bit forever without any clinical consequence or without having any kind of clinical sequela from that. The question was, in the new risk calculator, systolic blood pressure is on the list, but not diastolic blood pressure. And I would say there are probably 2 reasons for that. The first is more of a logistical reason, is that in most of the trials that were done, it was the systolic blood pressure that was recorded more than the diastolic, but I think that's a very small explanation for it. I think the majority of the reason is as we get older, it's really our systolic blood pressure that tends to go up more than our diastolic blood pressure. There are certain races and ethnicities and certain patients who raise their diastolic blood pressure, but if you think about what systolic blood pressure is the blood pressure during systole, when the heart ejects. And what the diastolic blood pressure is the blood pressure during diastole, when the heart's relaxed. So we have to have blood pressure at all times, right? Because blood has to be flowing to our organs at all times. So our diastolic blood pressure, which is when the heart's not pumping, can't be 0. But as we get older and our arteries get stiffer and we get calcium deposition and the walls of the blood vessels harden, the thing that seems to be affected more is the systolic blood pressure, because that's when the heart's actually ejecting. So the delta pressure, if you think about when the heart's ejecting into a stiff-walled artery, goes up more than, for example, the diastolic blood pressure, which is when everything's kind of in a neutral state. So that's one of the reasons I think the systolic blood pressure is probably focused on more in the risk calculator than the diastolic.
Could I just add something too?
Please.
I feel that I would be irresponsible if I didn't, since the blood pressure issue has been raised, to say that, we did not, really talk about blood pressure here. And blood pressure is actually the most important risk factor, along with exercise, but it's the most important cardiovascular risk factor worldwide. And that's pretty important to pay attention to, because in terms of knowing your numbers, really in addition to knowing your cholesterol numbers, you really need to know your blood pressure numbers. And frankly, the stroke rate and heart attack rates in this country vary tremendously by race ethnicity. And the larger burden of that is in certain Asian populations and in African American populations, and blood pressure control is really, really important. Cholesterol control is important, but relatively speaking, not as important. So really, really important to